Dr. Nishat
Nishan.
Ahmed, and I am Dr. Satyajit Sinha. Dr. Rashmi Jain is here, and Dr. Jayashri Barua is here. So, Dr. Nishat Ahmed will be speaking on microbiological and clinico-epidemiological analysis of cases of EKC during an outbreak in Delhi. And you have 5 minutes, and because we are marking this, so we'll be very strict about the timing. Thank you.
A very good morning to all present. So it was in mid-monsoon of 2023 that we saw a surge in the conjunctivitis and keratoconjunctivitis cases in the casualty of our center, and the occurrence of an outbreak of EKC was established. When we think about microbial causes of EKC, the first and foremost are viruses. Adenovirus and enterovirus, they cause most of the outbreaks, while HSV can also cause few clusters. Amongst bacteria, gonococci can cause clusters in neonatal wards and nurseries, and chlamydia in the setting of overcrowding and poor hygiene. Amongst parasites, microsporidia, especially in the backdrop of monsoon, holy dips, and exposure to other water bodies, can lead to EKC outbreaks. Bacteria as well as fungi, they can cause secondary infections in the pink eye as well. So we commence this study for clinical and epidemiological analysis and complete microbiological workup for identifying the etiological agents and secondary infections in the cases of EKC outbreak. These were our methods. We tried to recruit as many cases from the outbreak as possible, and we also kept 20 controls. Ophthalmic examination was done, and the sample was collected conjunctival swab. So for viruses, we did a multiplex PCR targeting all the important DNA viruses, herpes simplex virus 1, 2, VZV, and cytomegalovirus, and a uniplex reverse transcriptase PCR for enterovirus, which is an RNA virus. We did primary microscopy for bacteria, fungi, and microsporidia. We diagnosed active infective chlamydia trachomatis using antigen detection method, direct immunofluorescence assay. Bacterial and fungal cultures were done using standard protocols. And these were the results. The total cases were 1349. Samples could be collected from 505 cases and 20 controls. Clinical and follow-up details were available for 112 cases. 77% were males with median age 33 years, and 69% were indigenous cases of Delhi. The clinical presentation was typical of mild to moderate epidemic keratoconjunctivitis, and the complications were few. So the primary pathogens could be identified in 330 out of 505 cases, which was 65%. Adenovirus was the most common pathogen in 34% of the cases, followed by enterovirus in 24% of the cases. And because we did the full microbiological workup, we could detect chlamydia, herpes simplex virus, microsporidia also. Interestingly, in the initial phase of the outbreak, we were able to diagnose adenoviruses in large numbers, but later on we were able to diagnose both enteroviruses as well as adenoviruses. Bacterial and fungal pathogens, which could be secondary infections or colonizations, were also diagnosed in some cases. And the most common bacterial isolate was Staphylococcus epidermidis, and most common fungal isolate was Candida. The patient management was based on ophthalmological observations, systemic features, and the microbiological reports. Most cases healed without complications in less than average 5 days of duration. Strain typing was also done of the pathogens, and it was found that human adenovirus strain 8 and Coxsackie virus A24 were responsible for the outbreak. Interestingly, the clinical picture of our adenovirus cases and enterovirus cases was totally similar. So in the same time, outbreaks were also reported from other parts of India and neighboring countries, and it was found that from central, western, and south Indian states and Nepal, the outbreak was driven by enteroviruses, and the clinical picture was of hemorrhagic conjunctivitis, whereas from north and northeast India and Pakistan, both enterovirus and adenovirus were identified, and the clinical picture was like EKC. Thus, we did a large number of cases in the EKC outbreak, and we could elucidate the pathogen association with epidemiology, and it helped in patient-specific treatment and favorable outcome in the patients. Thank you.
Thank you, Dr. Nishant. Dr. Jayashree, would you like to ask a question?
So this was a study where you analyzed not only the cases in Delhi, but you also combined the other states also.
Actually, ma'am, because ours is a tertiary care center, so
Okay.
we cater to like many nearby states also. So the patients, when they have some problem in the eye, they come to us. From even in the neighboring states, for example, they have come for something else. For example, a cancer patient is being managed, and their sibling or child develops EKC. Where will they come? They will come to our center.
Even the cases which had people who had just come and had incidentally
Yes.
got the infection,
Yes,
you have
yes.
included them also.
Yeah.
Okay, that
And
was
then
included
there are-
in the Delhi number.
Yeah, and
Okay.
there were people like who are traveling
Exactly.
and they developed a pink eye suddenly. So I have reached Delhi today and
Okay.
I developed a pink eye in the afternoon. So it is not an indigenous case of Delhi. It is from outside, but it is turning up to us like
Okay.
that.
Okay.
Dr. Rashmi?
So basically, to continue what ma'am said, this is not a pan-India study, it's of the center.
It
right?
is
Yeah,
from Delhi center.
Epidemic. So it's the state, it's the condition which
Yeah.
infections
it is a
which were
condition
happening
in our
at that
center,
time.
but we correlated because at that time we attended a lot of webinars and workshops
Yes.
during the outbreak.
to
So
this.
we interacted with
How do you
people.
think this study or this profile would help in the actual management of future cases? Is this any different from what's known about EKC already? And would it change our management?
Actually, ma'am, the emphasis here is on understanding that when an outbreak occurs, we sometimes overlook things which may be happening, but we might overlook them. For example, we were able to diagnose chlamydia.
Okay.
We are thinking of adenovirus and we are
Right.
detecting even chlamydia. The
Okay.
treatment is entirely different. So a whole microbiological
Was
workup
there any
and-
follow-up?
Yeah.
Was there any follow-up
Yeah,
based
yeah,
on
yeah.
the reports?
We 112 cases we could follow.
Okay,
And
okay.
like we found very good results. It is difficult in the setting of outbreak and a tertiary care center to follow each and every case.
True, very
But
true.
as many as we could, we did.
Okay, good study.
Thank you.
Dr. Nishant, nice presentation.
Thank you, sir.
I think Dr. Rashmi ma'am was trying to talk about something originality of what different are you trying to say in your presentation from what the delegates already don't know. So, and that was a good observation that you have made of how to do the management. So one thing which I wanted to ask, you have written very nicely that you took into account comorbidities also. So, because you are a busy center, were you able to see if there were patients like with uncontrolled diabetes or somebody who had a lower immunity were more susceptible to this infection rather than the normal patients?
Sir, the fact of the matter is, if the person is immunocompromised, then a colonization, because we did bacterial and fungal workup also. They were not primary pathogens, they were colonizers or secondary infections. So we decided to treat the colonizers also if the patient was found to be immunocompromised. That saves a lot of like morbidity to the patient, because a colonizer can become a pathogen if we just leave the patient like that. So that way we try to save the morbidity of the patient.
Thank you very much. Thank you.
sir.
Nice presentation.
Thank you, sir. Thank you, ma'am.
Now, once again, Dr. Anchal is here. Dr. Siddharth Mishra. Dr. Deepa Shekhar Das.
A very good morning, everyone. Can I have my slides, please?
Deep Shekhar.
Deep Sheikh.
Sorry.
So the topic of my presentation is retinal artificial intelligence in oncology, the promises and peril. So as we all know, that artificial intelligence is at the current moment, it's revolutionizing medical diagnostics, delivering faster, more accessible, and cost-effective disease detection tools across various spheres of healthcare systems worldwide. And ophthalmology is actually emerging as the ideal field for artificial intelligence implementation, particularly when it comes to retinal disease screening applications, with the key area of interest being diabetic retinopathy, age-related macular degenerations, and glaucoma detection systems. Medio's AI system, which has been devised by Remedio, uses combination of deep learning algorithms with smartphone-based fundus camera technology. And there are studies actually which has shown that it has been proven to be successful in screening diabetic retinopathy as well as glaucoma. So, however, as we are currently focused on cancers right now, so what we found that there is a limitation as well as lacunae regarding how it behaves when it comes to picking up retinal pathologies of cancer patients. So what we did was, we noted out what are the common retinal pathologies which are noted in cases of in a patient of systemic cancer. For example, the most common feature which is seen in cancer patients overall, it's leukemic retinopathy, followed by choroidal metastasis and optic atrophy in certain cases. So we performed a prospective observational study over 3 months at Ophthalmology Oncology Clinic of NCI, that is National Cancer Institute, AIIMS, New Delhi. We obtained informed consents and the required permissions. We included 98 patients with suspected or confirmed malignancies. The inclusion criteria being all of them either had or had some form of malignancy. They were cooperative or fit enough to undergo fundus photography. Exclusion criteria has included any form of media opacities or the patient not being able to cooperate or perform the procedure. So this is how we, this is the imaging protocol. We use the Remedio smartphone-based fundus camera, which is operated by trained technicians initially under standard lighting conditions. The regions which were captured were macular optic disc and peripheral retina, wherever accessible. And on side by side, we also performed a clinical evaluation by a trained ocular oncologist who evaluated slit lamp examination as well as indirect ophthalmoscopy. Outcomes were divided into primary and secondary outcomes, where we found out actually how much the AI was actually able to pick up pathologies. So these are the results. That is 98 of the 98 patients were enrolled for the study. Mean age was 52.3 and 55% were males. Here is a in this chart, actually, you can appreciate that majority of these patients had solid tumors. For example, intracranial lesions, which included breast carcinomas, as well as glioblastoma multiforme, medullopitheliomas, peritoneal macroadenomas, so on and so forth. So, coming to what was benefited by this study per se, what the AI was able to easily detect was firstly glaucoma. AI demonstrated excellent performance in detecting glaucomatous changes, correctly identifying pathological cupping in 3 patients, which was subsequently corroborated through comprehensive clinical evaluation by the trained experts. The cupping which the AI was able to detect was at least 0.7 with characteristic neuroretinal thinning. The image on the right side, you can actually appreciate that the left eye, there is significant cupping, which the AI actually even found the exact ratio, that is 0.79, whereas the right eye, there is 0.5, that is also quite significant to, for us to keep it monitored. So AI had roughly 100% agreement when it comes to picking up glaucoma. However, when it comes to diabetic retinopathy, AI flagged 10 patients having diabetic retinopathy. However, only 2 patients, just 2 of them had genuine diabetic retinopathy. Here is a correct diagnosis where there are exudates which have been picked up by the AI system. Moving on to age-related macular degeneration, AI had achieved 100% accuracy in picking up all of those patients with age-related macular degenerations. However, when it comes to leukemic retinopathy, there was 100% misclassification. None of the 8 patients of leukemic retinopathy was picked up by the AI system. They actually overlapped them, or they have flagged them, all of them, as diabetic retinopathy. Moving on to optic atrophy, the AI system, which was quite astounding, that it was able to detect glaucoma, however, it was not able to detect any feature of optic atrophy. There were 5 patients with optic atrophy, and none of them were able to be picked up by the AI system. So moving on to the discussions per se, there are currently lagging AI models which are which are able to pick up these cancer-related pathologies, and they can be easily missed out. Coming to the conclusion, the promise is that AI as of now is able to
30 seconds, please.
Yes, ma'am. This is the last slide. So, AI system has strong potential in detecting retinal pathologies. However, when it comes to complex scenarios, there is a lot of limitations. And at the present juncture, India needs to develop its own AI model, which we are currently working on as well. Thank you.
Thank you. Once again, I'd like to request everybody to please stick to the time. Dr. Jayashree?
Well presented, Dr. Devshekhar, but yes, the point to take back home is that AI is not above ophthalmologists. Ultimately, it's your clinical diagnosis that is going to help you more, and we as ophthalmologists, maybe we are lucky that it's not overheading us, right? But regarding the optic atrophy which you mentioned, it's surprising that it's being able to detect the cup size, but somehow the atrophy which was distinctly visible in your fundus photo which you showed, it was not able to detect. So that means we cannot rely totally upon that.
Ma'am, I went and read about how it actually identifies the factors. So these CNN models, they look at the edges.
Yes.
So they have to have an edge to find out. They are not trained enough to find out color differences. So optic atrophy is mostly related to color changes.
Means you need to have a minimum rim edge, rim size, so that the AI is able to detect.
No, even if we have to train a separate AI model for picking up color changes.
Maybe 0.9 will also be not labeled as glaucoma, or maybe not even as optic atrophy, sir.
Yes.
Your point?
Dr. Rashmi?
So interesting study, but one basic technical flaw. Remedio is basically, it's designed to, all the deep learning algorithms are only for DR, ARMD, right, and glaucoma. So that's what it detects.
Yes, ma'am.
Right? It is not fed or trained to detect optic atrophy.
Ma'am, what we're expecting, because optic atrophy and glaucoma, to a certain degree, we see that there is similarity when it comes to the appearance
so
of
you
the
were
optic
looking if it can catch the cup.
Yeah.
Yeah, but that's not what it's trained on.
Ma'am, it has been trained on detecting the cup size and flagging
Yeah,
it.
glaucoma
So,
characteristics.
yeah.
The entire training of this particular Remedio is only for these three, which it was very well, it was catching them well. You had 100% catch rate there.
Yeah, for glaucoma.
And why do you think it had a problem in identifying diabetic retinopathy and leukemia changes?
Ma'am, these are quite overlapping symptoms.
Exactly.
Yeah.
So it is catching them like features of diabetes.
They're flagging it. That's a good
Yeah,
thing about.
yeah.
So we have to train it further more so that we can diversify.
Yes, so your
the
conclusion
diagnosis.
probably would be it's good for doing what it is supposed to. It's not trained to catch leukemia
So you have to
lesions.
train it.
Yeah.
That's
So,
the whole
the
idea.
conclusion would be more like we need to create a Remedio or a model where we can diagnose
We are
other
already
things.
working on it, ma'am. That's what I include.
All the best for that.
Thank you.
Okay, thank you.
Wonderful presentation, Dr. Deep Shekhar. Basically, I think over time, AI will develop more and they'll catch all these things as we have been discussing. In this presentation, it appears like you have put everything just together, what AI is already doing and what we already, Remedio is doing. What was your contribution per se directly for this scientific presentation? You have taken what AI is doing.
No, sir. It's more of a validative thing which we are doing. I was the person who performed the clinical examination. I was the clinical expert who verified that whether the Remedio, whatever the findings it has flagged, is actually, because all these 98 patients which we have seen, I have seen it myself personally and verified that whether the model has picked up anything or not. There are instances where the drusen's were there in the periphery, but still the AI was able to pick up. Okay, in the later on studies actually.
So you're basically doing an audit of the AI.
Not directly per se, but I'm just an end user.
And the other thing which I wanted to tell you is, as an advice, do not use institution names in your presentation. You said National Cancer Institute, AIIMS, New Delhi. It makes the thing biased. So in future presentations, don't use name of institutions. Thank you very much. You want to call the next person?
Dr. Siddharth, I guess, are not here as yet. So I'd like to call upon Dr. Sushma Raj. She'll be speaking on blinded by the lights, spectrum of laser-induced retinal injuries. Over to you, Dr. Sushma.
Good morning, everyone. I am Dr. Sushma from Shankara Eye Hospital. Today, let's see some cases in the spectrum of recreational laser-induced retinal injuries. So, can I move my slide? Yeah. Coming to the case one, 11-year-old boy presented with.
Can you be a little louder?
Am I audible, sir, now?
थोड़ा सा वॉल्यूम बढ़ा दीजिए. ऑडियो विजुअल.
Am I audible now, sir? So, coming to the case one.
Now we can hear you.
Okay. So, 11-year-old boy presented with the blurring of vision in both eyes since 1 month. So, upon asking, there was a history of playing with the green pointing laser light towards both eyes since 1 month ago. And the parents of the child came with the laser light he was playing with. And upon examination, it was a green laser light, and the spot size was 3 mm. It was mentioned, power was less than 1000 milliwatts. Wavelength was 532 nanometer, and it is categorized under class 3 laser. So, the best corrected vision in both eyes was 6/12, and his anterior segment examination was within normal limits. On fundus examination, in both eyes, the FR was absent, and a circular scar was present at the fovea with foveal and parafoveal pigment alteration. And OCT of the both eyes revealed a lost foveal contour, loss of interdigital zone and ellipsoid zone, and there was a subfoveal subretinal hyperreflective material, and there was a PED with surrounded by a shallow neurosensory detachment. And when we did the octa, there was in the NFAS octa, the vascular network was seen in the outer retinal slab, coinciding with the flow signals in the cross section. So we went for the FFA for the confirmation. In both eyes, there was a central hyperfluorescence increasing in the late phases, seen in the late phases with increasing size and intensity, suggestive of a leak, confirming the presence of CNV. So, and the diagnosis was both eyes laser-induced CNV, and we managed it with the intravitreal anti-VEGF injection for both eyes. And due to the logistic purpose, the parents were not able to come to a hospital, and after 1 month, in the 1 month revisit, there was an improvement in the vision, and the vision improved to 6/9. So coming to the case 2, a 41-year-old male presented with sudden decrease in vision in right eye following exposure to the laser lights at Ganesh Visarjan festival last year. So the best corrected vision in right eye was 160 and left eye was 66. His anterior segment examination of both eyes was within normal limits. So fundus examination revealed a well-demarcated board-shaped hemorrhage with depicting a subhyaloid hemorrhage, and also a subilum hemorrhage component was also there at the macula, obscuring the underlying retinal vessels. So the OCT revealed the lost foveal contour and a heterogeneous hyperreflectivity obscuring the underlying retinal architecture. So there was a subhyaloid and subbilum hemorrhage. So diagnosis, laser-induced subbilum hemorrhage. So we advised the patient to go for YAG hyaloidectomy, but the patient was not willing, so we went for observation. After 1 month, the best corrected vision improved to 2/60 only. There was not much of an improvement. And in the fundus examination, there was an resolving subhyalum hemorrhage with the dehemoglyzed bleed. And in the OCT, the subhyaloid hemorrhage is almost resolved, and the subhyalum hemorrhage has reduced in size. So coming to the discussion, use of these lasers have gained popularity over the years in various sectors due to their easy availability that has increased the exposure risk. And we already know that these DJ music festivals, laser shows, DJ shows, these shows have been used by these class 3 and 4 lasers. So the optical structures in the eye condense the laser beams, especially those within the wavelength within the visual spectrum on the retina. So they amplify the laser irradiance by 5/6 times. So this makes the retina most vulnerable tissue to the accidental laser injuries. So as seen in the case 1, majority of these will be handheld laser pointers, mostly being used by the children as play toys. So the pointer that was used by the child was playing had a power of less than 1000 milliwatts in the wavelength 532 nanometers, which was categorized as a class 3 laser. And as we know, for PRP also, for pan-retinal photocalculation also, we use the laser with the same wavelength, but with a much less power, that is 50 to 200 with the titration. So when we went for the literature, similar incidents have been reported. These have been well documented before. As you can see, then there was an outbreak of subhyaloid hemorrhage after accidental laser exposure during an Indian festival. It was reported in 2022 September. For the details, 34 men reported with a sudden outbreak of subhyaloid hemorrhage due to the malfunctioning lasers, which is categorized as class 3 lasers. So still they are commonly available and being used in the recreational activities. So the indiscriminate sale and use of these class 3 and 4 lasers should be regulated. These unregulated use in public spaces poses a serious risk. Not only retina, they can affect other parts of the eye and cause other complications like radiation cataracts, corneal burns. And they can also affect skin, as we know. So we need to make people aware of the consequences of the laser.
You need to end, Dr. Shushma. You just get 30 seconds
So
more. Okay.
environmental control and stricter regulation, product labeling, and public awareness should essential to prevent these avoidable vision-threatening exposures, as prevention is the best cure. Thank you.
Okay, very well presented. Just 2 points I would like to know. One is, what is the amount of exposure that you would like to predict that is responsible for such cases, and the time of presentation?
Yeah, yes, ma'am. In the case 1, the boy was, as we got to know from him only, he was holding the point laser at maybe at half a meter distance from the eye. He was playing like this, as told by him.
Was it a single episode, or was it doing it continuously for 1 month? It was a single episode.
Yes,
and regarding the second case, how old was what was the age of the patient?
Second case, 41-year-old male, and
41
he
year.
presented right after loss of vision.
Okay,
Next
and
day
you
only.
ruled out the other possible causes of hemorrhage in such case?
Well, silver retinopathy and all, we asked about the DDs and all, but right after the exposure for about 2 to 3 minutes, he reported that he lost sudden loss of vision in the.
Okay, ma'am.
Since you ended by telling prevention is better, what would you advise? It's a class 3 laser, right?
Yes, ma'am.
Class 4, we have all the warning signs and all. What about class 3?
So,
What would you
yes,
advise?
ma'am. Class 3, these lasers come under 3B, like more than 5 to 500
Right.
nanometer. So we are emphasizing on the public awareness mainly. So maybe we can avoid these malfunctioning lasers and.
Why not ban them?
Yeah.
I'm just, advocacy is
Yes.
also part of our job, right?
Actually, we should ban them.
Yeah.
But yeah.
And of course,
Regulated,
creating
maybe
awareness, but why
stipulated and
not?
Regulated use can.
Yeah, so good
Start.
study. It's something which is really requires creating awareness. So everybody talks of eclipse blindness. Nobody thinks of this also, you know. Okay, all right.
Thank you. You did a nice presentation. We already knew about this, but once it comes again, it really
So
refreshes.
these 2 cases came with us within a year, so we wanted to.
Thank you very much.
Thank you.
Dr. Deepti will be presenting on pediatric eye awareness, a cross-sectional study of pediatricians' knowledge and practices.
Good morning, everyone. My paper is a cross-sectional study of pediatricians' knowledge and practices, a pediatric eye care awareness. We all know that most of the pediatric blindness is either avoidable, preventable, or treatable. But this only happens when it is detected early and treated early. And this is where the role of pediatricians stands, because they are the first point of contact. They are also repeated point of contact, because whenever a child goes for vaccinations, pediatrician can screen for potential eye-related issues, and parents entrust pediatricians more than us ophthalmologists. So the purpose of this study was to assess pediatricians' knowledge, understand their attitude, and to evaluate their practice patterns in pediatric eye conditions. This was a cross-sectional study of 219 pediatricians where they were presented with a structured and validated questionnaire, and the data was analyzed using descriptive statistics. The questionnaire had 4 parts. Part 1 was part of doctor details, part 2 was knowledge assessment, part 3 attitude, and part 4 practice assessment. Each part had 5 questions each. The topics ranged from vision assessment to pediatric cataract, glaucoma, and went up till cortical visual impairment. Most commonly, the pediatricians had a practice of about 11 to 20 years of experience. Males were predominant gender, and they were practicing in private hospital. Though they had a very good knowledge about pediatric eye care conditions, the lacunae still persisted. Only 40% knew when to refer a cataract to the pediatric ophthalmologist as to about a lacunae about earliest age of cataract surgery. 50% of pediatricians were treating CNLDO by themselves only with antibiotics or by a wrong way of massage. 40% of pediatricians thought strabismus just as a cosmetic problem, so they referred them only when they were of a school-going age, resulting in amblyopia. And 30% of pediatricians thought that retinopathy of prematurity could be treated when the patient is fit to be transferred from NICU. Surprisingly, 81% of pediatricians knew about cortical visual impairment, and then they knew about the multidisciplinary rehabilitative approach. Coming to the attitude part of pediatricians, 95% of them said yes, eye examination should be done regularly in every child. But only 82% agreed that it should be done solely by ophthalmologists. They also took an onus of eye examination. But unfortunately, 13% were not adequately equipped even to diagnose or refer a child with eye diseases. So this is the attitude part of the pediatricians. The practice patterns, 98% performed torchlight examinations. Only 9% went beyond torchlight examination into movements, visual acuity, and fundus evaluation. 59% performed torchlight regularly in every child which was given to them, but only 13% accepted that we did not know how to perform a thorough eye evaluation because of our training gap during the residency. So the outcomes of these studies are, the knowledge of pediatricians are absolutely very good, but then attitude and practices were variable depending on the age as well as the places where they were practicing. The gaps in standardized screening resulted in delayed referrals, which resulted in treatment delays. Contrary to expectation, rural doctors referred us very frequently, whereas the urban pediatricians treated them unnecessarily or under-treated the children, resulting in delays in proper care. The gaps we identified were lack of confidence in performing full eye examination among the pediatricians. They had a delay in referring specially cataract, strabismus, nasolacrimal duct obstruction, and retinopathy of prematurity. And there was a limited training of cortical visual impairment and retinopathy prematurity management pathways, which are most commonly presented to them in the first scenario. So the recommendation which we would like to put forth is, as now AIOS has got a motto as pediatric eye care for the next upcoming years, it should be onus on us as well as on the ophthalmologists to conduct regular training programs for pediatricians about the pediatric eye health. We need to strengthen the referral links of pediatricians with the ophthalmologist and include vision screening training program in the PG curriculum, especially for pediatricians. So we need to remember that pediatricians are not just meant for cold, cough or fever. They are the gatekeepers for a child's overall development. The onus lies on us ophthalmologists to guide them, because today's children are tomorrow's future. Preventing their blindness and an early referral is what would make this future very bright for us. Thank you.
Very nice, very nice.
Wonderful
This is the kind of
presentation.
originality we were looking for. Okay. Dr. Jayashree?
Indeed, a wonderful presentation, Dr. Deepthi.
Thank
Well
you,
done. The point which I like to highlight, yes, the most of the pediatrician, they don't refer to you, and treating them with antibiotics just for the sake of giving an eye drop, saying that I have seen the patient, he or she is having some eye problem, and prescribing the antibiotic, it's not. So what we need is a link between the pediatrician and the ophthalmologist, which is very important. And yes, wrong technique of massage, it's equivalent to no massage.
Yes, ma'am.
So very well presented.
Most of the parents told us that they did go to the doctor, but then the doctor told them that at 1 year an ophthalmologist will take over for CNLDO.
Yeah.
Before that, an ophthalmologist
And
doesn't
I
play a role.
make it a point that when the parents come to me and they say, no, that we have been doing the massage, I just ask them, show me the technique which you are using, and then you come to know where actually the flaw lies. They are doing their job, they are teaching them the massage, but we need to just refine their massaging technique. We need to convey to them that this is the correct technique.
Yes, ma'am. Thank
Well
you.
done.
So, Dr. Deepthi, well presented. A topic very close to my heart. Okay, I'll tell you why. It deals with our training. So, you made one of the recommendation during PG training. We should address the gap. I say we start addressing it from UG, right? Vision screening is one of the must-know competencies. Also, one very important point. You mentioned about referral. Can we use a better word and say interprofessional training, interprofessional working? Right? We also err when we are seeing a child, we just look at the eyes. We fail to catch many other things. Similarly, they fail to do that. So probably our training needs to start from early. ROP is very close to me, especially when it comes to training component. Right? So I think that is where we need to catch the gap and build in more of interprofessional. Referrals will come when they know what we are doing. There's a huge knowledge gap actually.
Yes,
right? They want to, but they don't know what to.
True.
So I think we should focus in one of the recommendations you said that more webinars, more talks and all, right? I think we need to focus more on skill building. Talks is one component, probably more of skill building.
Hands-on for them.
Yes. So I think that little modification in that advocacy, skill building and IP.
We also have to learn many things from them.
Yes.
Like
I
as
mean,
ma'am
we
has
always
said,
think
we
you-
focus on the eyes. Exactly,
Yeah.
ma'am.
We think they are not referring for them. Life of a baby in ROP is more important. They are trying to save the life. They're like, okay, vision will come. It's from practical experience what I am saying. So they don't think we can refer. So the moment we catch them, yes, you do your job, we'll do ours. That's where the difference comes. So
Point.
learning together so that we work together.
Point
Good.
taken, ma'am.
Thank you.
Dr. Deepthi, wonderful presentation. Just continuing in the advocacy part, the recommendation that you are suggesting, I think next conference of Indian Pediatric Association or wherever, we ophthalmologists should also in their state conferences put our presentations, just like we make submissions for AIOS, we should make submissions, talk to the secretary, put a presentation in their annual conferences where there are 100 of pediatricians sitting. So that would be good, like in Karnataka or elsewhere. But wonderful presentation. Thank you very
sir.
much.
Thanks a lot, sir.
Can we have Dr. Ashwita? Dr. Ashwita will be speaking on Made in India plug brachytherapy, improving availability with a cost-effective indigenous solution. Over to you.
A very good morning, everyone. I stand here to proudly present the self-reliance and success story of the Made in India plaque brachytherapy, which was initiated by the Baba Atomic Research Center in coordination with our mentor, Dr. Santosh G. Honawar. The first successful use of plaque was by Foster Moore way back in 1929, where it was used for the osteosarcoma. From there on, various designs and isotopes have been curated. Why did we choose ruthenium? It's a beta emitter, had reduced collateral damage to the surrounding structures, had a longer half-life and lesser radiation side effects. The initiation of brachytherapy in our country, India, was with BBIC plaques, which was imported from Germany for its use. However, this was accompanied by exorbitant prices and severe import restrictions. It wasn't just a price tag, but a big barrier that confined these essential products to the hands of the affluent. The story of the BARC plaque came from the high-level waste from nuclear reactors, which was typically deposited hundreds of meters below the earth. This is now being harnessed. From the heart of the Kalpakam nuclear reactor, this waste was extracted and turned into the BARC plaque, showcasing the potential of a sustainable innovation. From here, we developed the notch and the round plaques and successfully did the Made in India BARC plaque. After separation of the radionuclide from the high molecular waste, it was immobilized and encapsulated between two silver substrates. We aim to assess the local tumor control, outcomes, and also the safety and efficacy of this indigenous Made in India plaque. This is a retrospective comparative interventional case series conducted over a period of 11 years, where clinical and radiological assessment was done and the dimensions were calculated based on its diameter and its height. The plaque shape and size was selected and the dosimetry was calculated. Finally, after appropriately locating the tumor, the hot plaque was secured onto the sclera. Out of a total of 101 patients, 70 received it as a primary treatment and received it for a mean duration of 32 hours. Totally, 34 of surface tumors and 80 intraocular tumors were treated with this indigenous plaque. Vision salvage was achieved in a majority of patients of OSSN, conjunctival melanoma, choroidal hemangioma, and retinoblastoma. Prognosis was mainly dependent on the location of the tumor. This is a comparison of the tumor outcome of both imported and the indigenous plaque. 90 to 100% tumor regression was seen in patients of uveal melanoma, metastasis, hemangioma, and OSSN. Here are some success stories from our brachytherapy archives. Extensive ocular surface neoplasia with scleral invasion was effectively treated by the plaque rotations done in several cases. Conjunctival melanoma treated with an apex dose rate of 10,000 centigrade. Choroidal melanoma treated with the tumor apex dose of 10,000 centigrade to the clock hour with the maximum height coupled with a prophylactic protocol-based 3-monthly anti-VEGF injection to prevent radiation retinopathy. Choroidal hemangioma was treated with a plaque dose rate of 4,000 centigrade, which shows almost complete regression of the lesion and the subretinal fluid, achieving an improvement of vision from 624 to 69 parts. Plaque brachytherapy in retinoblastoma was reserved to patients who are refractory to all other modalities of management. The BARC plaque was also in accordance with the set criteria of the American Brachytherapy Society consensus guidelines. All the parameters of the quality standards were also met, with lesser number of hot and cold spots and the leak test being negative, suggesting that it is of supreme quality. When we did a review of literature, we found that the indigenous plaque was at par with the imported plaques, both in terms of safety and efficacy. But what stands out that it is available at a cost, available for a larger population. At a fraction of this cost, we achieved 62% life salvage, 98% globe salvage, and 100% life salvage. This is one of those largest studies which proves the efficacy, self-reliance, and success story of the plaque brachytherapy, which achieved both globe and vision salvage in patients where enucleation was the only option, and especially at 5% of the cost, making it available and accessible to a large population. It matches the imported plaque in outcomes, showing that it's not just an alternative, but also a solution. A true example of transforming healthcare with indigenous innovations, delivering quality care, accessibility, and equity to all corners of the society. Thank you.
Dr. Ashwita, was this study, procedure, surgery, was it done by you?
Yes, sir. Under my mentor, Dr. Honavar, he performed the surgery in all the cases, and we collected the data. It was a retrospective analysis study.
Dr. Jayashree?
Well presented, Dr. Ashwita. It was a nice presentation. Thank you, ma'am.
What about the scalability? This is currently being done in only your center.
Yes, ma'am.
What about scalability, mass production of this?
It's also done in, I think, 2 other centers, AIMS, and also one of my colleague, Dr. Shalin, has been doing it. So
Okay.
they have to follow a regulation, and where
Yeah.
they fill in a form and submit it to the Baba Atomic Research Center,
Right.
and also give them a guideline as to when would they require and which year plaque would they require, and then the
Okay.
Atomic Research Center checks all the radionucleotide standards and then sends it off to
Okay.
them.
Okay, so it's only 3 centers. Scalability is still happening slowly.
Yes, because it is primarily done in oncology referral centers.
True,
So
true.
those practice centers do,
Themselves are
yeah.
little less so.
Yes.
All right. Okay. All the best.
Thank you.
Now request Dr. Ankit Agrawal. Dr. Ankit Agrawal? All right, not there. Can I call on Dr. Amandeep Hans? Yeah. Dr. Amandeep will be presenting her paper on evaluate screen time, sleep quality and its association with dry eyes amongst medical students.
Should I start, ma'am? A very good morning to all. Today my topic is evaluation of screen time quality of sleep and its association to dry eyes in medical college. So dry eyes and sleep disturbances more prevalent in the digital age, commonly seen among these medical students exposed to prolonged screen time for academic and recreational activities. Prolonged screen use versus the dry eye disrupts the sleep via the blue light and increase the stress, impairing the performance and the well-being. So the main purpose of our study is to evaluate the association between the screen time, dry eyes and the sleep quality among the medical students. It was a single center cross-sectional questionnaire based observational study conducted at AIIMS Mohali. The data were collected using a structured online Google form comprising the standard patient evaluation of dry eyes and 10-item mini sleep questionnaire. To our result, a total of 401 medical students were enrolled, in which 238 were females and 163 were males, with an average age group from 21 to 23 years. So the daily screen time of more than 4 hours were noted in around 259 students, counting to 64.59%. And the screen usage was mostly during the evening and the night. Patients also had history of dry eyes, allergic disease, glaucoma, and other refractive errors were also noted. So the final assessment, the speed score category, we noted there was a total of 33 students which had severe dry eyes, followed by moderate, which was 33. However, 335 had no to mild symptoms. Whereas in mini sleep score range, there were around 90 students who had severe sleep difficulties. So the other variables were also noted. The iPad users were most common, followed by the TV users which had symptoms of dry eyes. The maximum screen time was used during the weekends, days and weekend nights. Also had history of dry eyes in 6 children which had moderate to severe eyes. And there was usage of eye drops in 52 cases. So then the final association was done, a one-way ANOVA test was done, which showed that the screen time showed a moderate positive correlation with the speed score, indicating a higher screen usage is associated with increased dry eyes. And screen time also had a significant positive correlation with the mini sleep score, suggesting a longer screen exposure is associated with the poor sleep quality. So to discuss, a 401 undergraduate medical students with the females 59.4% with the mean age of 21 to 23 years. In the present study, 64.6 wore the corrective lenses which had the higher than the earlier reported, which was 37 to 54%. Our study found 64.6% of the students spent over more than 4 hours on the screen, echoing with the Gupta et al. That was 45.5%, exceeding the 6 hours. The peak screen usage was in the evening and the night during the weekdays and nights, likely worsening the eye strains and sleep quality, which has been noted earlier. The iPad showed a substantial burden with 56.1% reporting the mild symptoms and 12.2% experiencing moderate to severe dry eyes. Usage of eye drops and the students who frequently felt tired upon waking up showed a greater tendency towards the moderate to severe dry eyes. So the collective reinforcing association between extended digital screen with the burden of dry eyes and the sleep pattern disturbance. However, there were few limitations to our study, that it was a cross-sectional design, self-reported data limiting the accuracy and no causal proof. And there was an uncontrolled factors like environment, screen use, diets, etc. So to conclude, our study confirms a strong association statistically significant between the screen, dry eyes and the sleep pattern disturbance. Medical students form the foundation of the healthcare, yet neglecting their own health, placing them at a risk of poor academic and clinical outcome. There is need to promote digital wellness, regular screen breakups and sleep hygiene, educate to reduce these adverse effects. Thank you.
Thank you, Dr. Amandeep. I would like to know what were the inclusion criteria in your cases? Did you include all the students of a session, or how was it like? You didn't mention about it actually.
Ours is a newly established medical institute. So we had a total of 4 years of MBBS students are there. So we asked them, we opted them, we told about the study, and then we asked them if they are ready to enroll. So we enrolled only those children who were ready for the study. And children who didn't give consent, that was fine with us.
Okay, and it was through a questionnaire, it was through a Google
Yes,
form.
ma'am, it was a
Okay,
questionnaire.
did you recheck the cases clinically? Did you examine the cases clinically?
Yes, ma'am. So that comes at second part of the study, so which is under the process. So basically, we have a total of 66 children who have dry eyes. We have clinically noted them, and we have also seen that they were using dry eye treatment or not, or were there other confounding factors or not. And now we were able to counsel them around 40 children which we have counseled to avoid the screen time and decrease the screen time from less than 2 hours. And so that is the second part of the study, and after 6 months we will be concluding that study also.
Okay, and also in the 66 cases, I would like
Yes,
to term them as, even in the 66 cases, you need to be sure that there were not other causes of dry eye. You need
Yes,
to
ma'am.
rule
Yes,
those
ma'am.
out
Yes, ma'am.
also.
Yes, ma'am.
Okay.
We have done that. That is also. But this becomes our first study in India, since there is no study in medical colleges associated with dry eye, sleep, and the screen time, ma'am. There is one study though in South which use the OSDI score only, and so might be the first one.
So you mentioned no other studies correlating all the factors. You said it's unique because no.
Ma'am, only in the medical one. Yes, ma'am.
No, it's there. It's there in medical colleges. It's there.
I did, ma'am.
Yeah,
we
take back the
there. I
words
also
that it's,
agree.
it's not. It's good. I'll tell you what interesting is that you have tried to correlate sleep.
Yes,
Right? Lot of confounding factors, starting with the fact it's a self-reported study.
Yes, ma'am.
There are several studies, probably, like ma'am said, follow up, actual workup along with their own perceptions,
Yes,
or
ma'am.
what, they are reporting. That would add value to the study.
Yes, ma'am.
Yeah, like you said, second part of the
Yes,
study.
ma'am. Yes, ma'am. We
Yeah,
have this-
it's a known, well-studied topic.
Well-studied, yes,
We have still not been able to create the awareness which is required.
Yes, ma'am.
And it's an old topic, but yes, very much relevant still.
Yes,
Okay, all right. All the best.
Nice presentation, Dr. Amandeep.
Thank
What is the basic idea behind doing it for medical students? I think engineering students spend more time on the laptops and computers. What was the whole idea? Was it more of a convenience that in the same medical college you would get your subjects for study? Because
So
if I
this
were
was
in your
meant-
place, I would study it more for the engineering students than medical students.
Thank you, sir. But this was our personal experience, since we are taking classes of so many students. A total of 100 and 110 students are coming to us for the clinics and for the theory. Now the things have changed, sir. Earlier we were the person who were there with the copy and pen, writing all the everything. Now people come with the iPad with us. So even in the classes, even in the exam also, they come with their iPads and they are writing history examination over the iPads only. And when I ask them, do they have the books? No, ma'am, I have books in the PDF. You just tell me what topics I'm supposed
So
to
basically you're saying that medical students are sleeping lesser than engineering or law students, or medical students are
this
sleep
was-
deficient, and which is why the incidence of dry eye. But thank you very much. Nice presentation.
Thanks.
Dr. Saroj Gupta. Dr. Saroj Gupta. All right. So we'll go. Shall I call these? Ha, shuru se. Okay. All right. Dr. Achal Tripathi. Not there. Okay. Dr. Siddharth Mishra. Not there. Dr. Arhan Shah. Not there. That's all. Dr. Ankit Agrawal. And once again, Dr. Saroj Gupta. Okay.
Did we miss out on calling anybody who is here who has to present? Okay, thank you very much. That brings us to the end of this session. I'd like to thank Dr. Jayashree Barua and Dr. Rashmi Jain and myself, Dr. Satyajit Sinha, and the wonderful presentations. You all did a very, very nice presentation. The marks will go to the scientific committee. But congratulations to everybody. Congratulations to everybody. It was a very nice presentation. Thank you very much.
Since we have 10-15 minutes more, it seems Dr. Saroj is in another hall, so we can wait for maybe another 10 minutes. They are calling her up.
She said
Since
she'll
we
come.
have time, she said she'll
Okay,
come. And since we have a few more minutes, I would like to highlight some points regarding the presentations. All of you have made wonderful presentation, but regarding the font size, that is something that you have to look for. And no using fancy fonts where you can't even make out what word actually you are going to display. So these are some finer points regarding the presentation which you should take care. It's not that you try to make it so different that people in the audience, they don't apprehend what actually you are trying to project. They'll be more into seeing the decoration of your fonts, okay? So we need to be careful regarding the size of the font, and it was good that there were no too many words clubbed up in a single slide in any of the presentations. But yes, the design, the font design is important. Kindly take note of that. Thank you.
Dr. Arvind Maurya, sir, you are into teaching a lot of postgraduates. Can we invite you to share a few pearls of how to make presentations? Because we have time. Dr. Arvind Maurya, sir, is professor at AIMS, Hyderabad.
Thank you so very much, sir. So, very good morning, esteemed chairpersons and my dear friends. So, in presentation, we need to first look at the timing. So, how much is the time? Suppose the time is 5 minutes. So, we need to have 10 to 12 slides. That is more than enough. And if you have video, then you need to further reduce your slide number. Now, coming to the colors, so they must be contrasting like black and white, right? They must not be too bright. So that makes uncomfortable for everyone to read that thing. And not too much knowledge in a single slide. I think eight lines are more than sufficient in a single slide. So like this, and you need to practice it with your friends, with your colleagues, so that you have a great idea in finishing in time or before time. I always try to finish before time, all my presentation. So these are the things, and rest of the things the esteemed judges, they have already told you. So thank you so very much.
Intended. Planning for 4.5 minutes will give us that little breathing space. And like sir very correctly mentioned, if the knowledge we are trying to put in is less, automatically the content will be lesser. And practicing. The more we practice in front of our audience, the better our words, the choice of words. Instead of going endlessly, trying to just rattle off, we'll choose the words correctly. So that helps a lot. Any presentation, whether it's a seminar or a podium presentation like this. So.
Chief, come in.
Significant public health problem across the globe because of increase in the prevalence of myopia, and it has become epidemic in certain regions of the globe, particularly in East Asia and Southeast Asia. And it is an important cause of visual impairment, especially in affecting the school-going children. In East Asia, prevalence around 80 to 90% young adults have myopia, and in India, if we talk about India, and according to NIM study, it was 13.1% in young school-going children, and about in more than 15 years, it has become 20%. So there's a significant increase in myopia in last decade in rural children also. Previous studies showed that it's only in urban children that's more, but now in rural also the incidence is increasing. And this is because of the availability of the internet and more screen time and more indoor time, less outdoor activity. Or because of this, now the incidence is increasing in the rural children also. And this meta-analysis by Holden et al. Predicted that by 2050, around 50% of world population will become myope. And out of these, 10% are high myope, which is associated with visual impairing complications like the retinal detachment, macular degeneration, glaucoma, and the peripheral degenerations. And this is a meta-analysis from India also, which also concluded that myopia is an emerging public health problem in both urban and rural school-going children, and which requires an urgent effort. Looking at all this, we conducted a study to find out the influence of time spent outdoors on myopia progression by following these children over the period of 2 years longitudinally. So it was a hospital-based study done over a period of 2 years at tertiary care center. So we included all children of 6 to 14 years presenting with a decreased vision with myopia less than 0.5 or worse, and those giving consent. But we excluded children who had refractive other than myopia, had a family history of myopia because we wanted to exclude genetic factors, and patients with other anterior posterior segment disorders were excluded. So total 580 children were enrolled. All children underwent cycloplegic refraction. We prescribed them glasses. And children were followed every 6 months for 18 months, and every visit cycloplegic refraction was done to know the refractive error. Then we recorded the time spent outdoor activity. So we asked the parents to record the activity of their child at home and at school during weekdays, weekends, separately on a chart provided to them at home. And they were asked to bring this record every time when they come for follow-up every 6 months. And these activities were defined as playing in ground during break in the school or at home, or riding bicycle, running, even sitting in daylight was considered as an outdoor activity. So we calculated average time spent outdoor activity per day by dividing the activity in 7 days by total hours outdoor activity in week by 7. And participants were divided into various age groups. And then we did a search analysis of our data collected of 495 participants. And this is the table which shows the profile of all the participants, their myopia and their outdoor activity at all 4 visits. So first we record this chart shows the baseline data at the baseline visit, their myopia in spherical in diopters and time spent outdoors in hours per day. Then at first visit, second visit, third visit, what was status of the spherical equivalent at every visit, and how much the time they spend outdoor at every visit in next 1.5 years. So coming to the results showed there was an association between the spherical equivalent and time spent outdoors hours in these children. And this was determined by the repeated measure correlation. And what we found that it was statistically significant correlation was found between these two. It was negative, means those who have more outdoor activity has a less myopia progression regarding association. So this is the chart which shows the inter-individual association between myopia and outdoor activity during these 3 follow-up visits. And this dashed line represents a negative relationship between the myopia and the outdoor activity. Those who had a good outdoor activity has a less progression compared to those who have less outdoor activity and were indoor most of the times. Then we tried to find out the magnitude of relationship also between the outdoor activity and the their myopia. So what we found is each of increase in outdoor activity per day had a negative effect on the spherical equivalent by 0.6 diopters, and this again had a negative magnitude, means again those children who have more spending outdoor had a less myopia progression. So these study findings are closely in line with Sydney myopia study, which suggested a protective role of time spending outdoors on myopia in children of less than 12 years. Another study done in India, NIM study, they also showed the prevalence of myopia was less in children who are playing outdoor more than 2 hours per day. So what is the mechanism? Why the children has less myopia, those who are more outdoor compared to indoor? So it is said that it is due to the release of dopamine from the retina in response to daylight exposure, and this enables the elongation of the growth of the eyeball. So the strength of study that there are minimal recall biases because we gave a chart to the parents to record the activity actually and bring the calendar. Where other studies when we compare, they all had based on recall. They had questionnaire based. They had to ask the question to parents how much is the outdoor activity, but ours was a documented outdoor activity. And this follow-up study, so we could establish a relationship, causal association between the outdoor time spent outdoor and progression of myopia. Sample size is large, but limitation that is an institutional study. So it cannot be extrapolated to the general population. So to conclude, increasing our time spent outdoor activity at home and school is a simple strategy to prevent the onset and progression of myopia in these children. And this is the first hospital-based study which we have done in Indian school children in a tertiary care in India, and we have published this in IGO also. So lifestyle modification required to prevent this epidemic of myopia. We should encourage the children to play outside instead of spending more time on screen and in the indoors. Thank you so much. These are my references.
Thank you very much. Dr. Jashi, you have a question?
Wonderful presentation, Dr. Saroj. What are the recommendations that you would like to suggest to the schools regarding this?
Yes, this is something which is very important.
Because we know the recommendations for the parents, but what are the recommendations for the school or the educational
so
institutes?
School, they have to increase their break periods and encourage the children to go outside to play in daytime. And there are randomized control trials done in China where they compare the 2 schools. When one school, they added 1 extra hour of outdoor break period, and they followed from the 3 years, then found the onset and progression was less in those children.
Yeah,
so the school, we have to encourage that they should give more break period to the school children, and they should be encouraged to play outside than to sit inside.
That's what I wanted to bring out actually, that like we used to have 1 week, 1 sports day.
Yes.
One day was dedicated to sports, but now what is required for the kids especially,
Yeah,
that you have at least 2 hours of outdoor activities, because for parents sometimes it becomes difficult to regulate.
Yes.
But as teachers, when they are forced to go outside for 2 hours, I think that is more beneficial, and that is going to help more than academics.
And to decrease the screen time also, because now when
Yeah.
young children are looking at mobile 6 months, 1 year, 2 years, so screen
Yeah.
time has to be decreased and distance has to be more.
Yes.
These are the reasons to decrease the
Yeah,
progression.
Thank you.
Thank you. A very relevant study, and not too many cohorts are there like this. So
Yeah.
it's a very good study. IAP has already come up with recommendation
Yes.
regarding screen
Yes,
usage.
yes.
Maybe we also need to do something
Yes.
because advocacy is happening from them for ocular health. But we are only not giving up these absolute guidelines.
Yes.
So I think we also need to be having more such studies where we can have such recommendations.
This is the first study we have done, a follow-up study. for
Yeah,
2
so I
years
think we
and the
need
children.
many more studies like that.
Yeah, yeah. Thank
Right,
you so much.
thank you.
Nice presentation. This study was already done in other countries like Singapore,
Yeah, it
where
is
they have
done.
increased.
In India, sir, all studies are cross-sectional studies. India
Anything
is-
you have learned from that study and incorporated in this one?
Yes, sir, because their follow-up studies are there from Singapore also, where they followed for 3 years, and their randomized controlled trials are also. So we have done an Indian population was not done. So we have decided to do in our children also, and it's a hospital-based. Now we are doing in the population-based. Which is ICMR funded project we got, and now we are doing in the schools we are going, and we are
Good.
doing study in schools also based on this study.
Thank you very much. Thank you, and sorry for the delay for the next
Sorry.
chairpersons. Thank you very much.